clinically meaningful endpoints in trials aiming to arrest type 1 diabetes, if you ask 10 clinicians, they may come up with 10 answers, but in the end, they will all go back to what is relevant to the person living with type 1 diabetes. Here are my disclaimers for completeness. I do advise most companies who make agents or tools that help us treat as clinicians people living with diabetes. And here I show you my bottom line. To me, it is really all about reducing the burden of the disease and increasing quality of life in those living with type 1 diabetes, and if I may say so, the families living with somebody with type 1 diabetes. And of course, number one, the gold medal to me is insulin independence, curing type 1 diabetes, taking everything away, turn it and twist it how you will. That is the bottom line. If we can do that, we can stop all discussions. But then if we are going in little steps, and if you ask me as a clinician, what would be important endpoints, it would be reduction in the risk of hypoglycemia, in particular severe hypoglycemia, but also if we could reduce the variability of the glucose curves, the variability in glycemic levels that we see happening in people with type 1 diabetes, I do believe we would have reached a clinically very important endpoint. Now, first of all, can you make it go away? That is what people with type 1 diabetes, and especially also parents of children with type 1 diabetes newly diagnosed, ask us. And I just share with you the type of emails that I, as a clinician, get continuously. I'm involved in INNODIA, a network doing intervention studies. And so people say, please, please help us in postponing the moment where intensive insulin therapy is needed, postponing the moment where also complications of diabetes may happen. Now, this is a picture I want to share with you. I got from one of my patients, and he says, Dr. Mathieu, this is what it feels like living with type 1 diabetes day to day. I feel like walking a tightrope where there's the wind blowing, the wind of what I take for food, what I do for exercise, and then always estimating the amount of insulin I need to inject. And in the waters, there's the crocodiles of me knowing that if I miscalculate, there will be the acute hypoglycemia risk, but especially also in the back of my mind, there's always the fact that if I don't manage to control my glycemia, I will develop chronic complications. And these chronic complications are correlated with glycemic control. And we know from the old DCCT study that indeed there's a direct correlation with the higher the hemoglobin A1C, the higher the risk for the typical complications of type 1 diabetes, namely the microvascular complications, but in the end also the macrovascular complications. And we know again from the old DCCT that tight glycemic control can bring down these complications. But again, my clever patients say, yeah, bring down, but not to zero, Dr. Mathieu. And that is indeed what still lives in the head of our patients, namely this day-to-day struggle for tight glycemic control to avoid later on these complications. Now, what is the problem with these complications as a clinically relevant endpoint? It takes many years for these complications to develop. Now, what we also know is that these complications still contribute to loss of life in people with type 1 diabetes. And it costs life years all over the board, whether you're a man, whether you're a woman. So it is important because these complications are lethal. And when you express it as life years lost in people with type 1 diabetes, here an interesting study published from Sweden in 2018, where they looked at the time of diagnosis of people with type 1 diabetes, and they looked at the expected median survival for the people with type 1 compared to those who did not have type 1 diabetes. And you can see that if you are diagnosed as a boy before 10 years of age, you lose 14 years. And if you're a girl diagnosed before 10 years of age, you lose more than 17 years. So we need to do something, and patients know that this is because complications. Now that's chronic complications, but we also have the acute complications, the acute crocodiles in the water. And I already showed you severe hypoglycemia as one of the crocodiles, and severe hypoglycemia still happens. Indeed, it happens throughout all of the important studies that have been presented in recent years. But there's also, for instance, diabetic ketoacidosis that can be a lethal complication in those living with type 1 diabetes. But let's get back to severe hypo. What is the problem there? Well, we have different levels of hypoglycemia. Severe hypo is the hypoglycemia where help from a third party is needed or where there's a loss of consciousness. But we also have the other hypos. And I am curious to hear what my friends in the panel will have to say about the impact of these hypos, namely the non-severe hypos, below 70 or below 45 milligrams per deciliter, how that impacts on their life, and whether reducing that would be a clinically meaningful endpoint. Reducing severe hypos for sure would be a clinically meaningful endpoint. And what is so frustrating for us clinicians to see is that whether you take studies from the 90s, the 2000s, or even in recent years, the frequency per person year of severe hypoglycemia, despite novel technologies, despite new insulins, is still staying there, and people still have severe hypos. And severe hypos impacts acutely on the life of people with diabetes, cognitive impairment, morbidity because of falling, for instance, when you have a severe hypo, and unfortunately also mortality. And of course, long term, there's also the association of severe hypoglycemia with the fear of hypo. If you've had one, you don't want to have a severe hypo again. There's a reduced quality of life. In Europe, if you've had one severe hypoglycemia, you lose your driver's license for a couple of months. So again, a big impact on the quality of life, burden of diabetes, and then this association of severe hypoglycemia with cognitive decline and mortality later on. I showed you chronic complications. I showed you acute complications. But when you think of the burden of diabetes, we know that variability of glycemia impacts a lot on the burden of diabetes. People really need to reflect continuously on what to do with their insulin in order to have this kind of a flat profile, with times in ranges that are above 70, between 70 and 180 milligram per deciliter, where we want to be, and with good hemoglobin A1Cs in order to avoid these complications later on. But this is reality. This is what people with type 1 diabetes need to live every day. And so coming back to clinically meaningful endpoints for me as a clinician, I have to say everything depends on reducing the burden of the disease and improving quality of life. But still, if we can already affect variability of glycemia, I think we've done a little bit. If we can avoid hypoglycemia, especially severe hypoglycemia, we've done more. The silver medal. The gold medal is, of course, insulin independence, perhaps not for life, but perhaps for a few months, for a few years. And now I will turn to my friends and ask for their opinion on my clinically relevant endpoints. So I show you here how my fantastic patients look. This is the women telling me, Dr. Mathieu, go out there and find interventions that may give us a reduction in the burden of type 1 diabetes. So, dear friends, Melissa, Kyle, Marjana, can I get your first reactions to my clinically relevant endpoints? If I can go to Kyle first. Kyle, in your opinion, what are clinically meaningful endpoints to you?
Yeah, thank you for that presentation, Chantal. You know, when I hear as a person living with diabetes, when I hear clinically meaningful endpoints, that string of words doesn't mean a whole lot. But when I see the presentation you've just given, it of course ties to my daily struggles with diabetes. But it's so hard for me to prioritize one thing or another, because in my experience day to day, they all seem so connected. If I'm going to have a glycemic excursion, whether it's hypoglycemia or hyperglycemia, but particularly in the case of a hypo, it changes my entire day. And if I have certainly if I have a severe one, but if I have one that's not considered severe, it's still going to impact the next 4 to 6 hours. And what's so what's particularly trained as an engineer, I think what's so frustrating about day-to-day management of diabetes is that you have an input into a box and the output's not always the same, even if all the factors are seemingly the same. And so one day to the next, I may have the exact same food at the exact same time, coming at approximately the same blood sugar, and the amount of insulin that I need for that is different. So from a scientific standpoint, it's far from perfect, and the tools that I have today don't seem to allow me to get anywhere close to perfect in terms of day-to-day management. So again, it's hard for me to pick apart any one of those. I think for me, hypos is something that I really struggle with, so that speaks to me loudly. But I'll allow my fellow panelists to follow.
I saw Melissa and Marjana, by the way, nodding heavily, but Melissa, you as a mom of 2 kids with type 1 and as a spouse of somebody living with type 1, clinically meaningful endpoints, what would be meaningful for you if there was an intervention in type 1?
So I think for each of the 3 type 1s that I have in my house, I think that those endpoints, each one of them speaks to different people in my house, right? So my husband really struggles with those lows, even with the best technology, right? He's on an artificial pancreas pump, one where his CGM talks to his pump, but he's still, it's a Band-Aid, right? A Band-Aid that we replace every 2 to 3 days unless a doorknob or something rips it off. And he can still have those lows where he needs assistance, especially like this weekend, he's going to do yard work. And we just know that even if he turns his insulin way down, he's probably going to have a low where he's going to need assistance. For my son, Connor, we knew that he was autoantibody positive for 3 years before he got type 1. And as a mom, there is no worse feeling than knowing that your child is going to get type 1 down the road and there's nothing you can do to stop it. I've heard of parents saying that it's like being hit by a runaway train. Like there's no time to process the diagnosis before you are smacked in the hospital with how to care for it. And so if there's a way to kind of slow down or delay that runaway train, it would be pretty meaningful to kids like Connor, even for a couple months or even a couple years.
Excellent, Melissa. And Marjana, you have had type 1 diabetes also a long time. So how do you experience this?
I would agree with everything that Kyle and Melissa are sharing, in that, you don't know what's happening every day. Every day is different. We're taking our insulin multiple times a day, and what happened yesterday isn't the same thing that's happening today. And once it's all in, there's no going back. And to, as Melissa just said, her spouse still struggles, and Kyle does with hypos. So do I. I'm also on an artificial pancreas type system. And just the other day, there was my husband standing over me with a glass of juice. I was not waking up to the alarms that were going off. We have 2 children now as well. And so I think about them in particular as I sit here and I listen to Melissa's story and think about my children who are at risk. How do I protect them from what I've had to go through? How do I leave something better for them? Is there something that could make things better, could protect us from the lows, protect us from the highs too, right? Because what happens is that scary low where I'm not waking up leads to an overcorrection. It leads to a rebound hyperglycemia, which then requires me to give myself more insulin, which more times than not leads to another low. This is all happening in the middle of the night. I can tell you that my ability to function the next day is impaired to do my job. It's something I think about when I'm driving a car. And we hear this from a lot of our families here at JDRF too, is that there isn't a second, an hour of the day that isn't thought about, where diabetes just isn't, it's always there. And it's so hard to, find, to keep doing what you're told to do, what you're taught to do, and the output still being something that doesn't give you the quality of life and the control that everybody says we need to have. Those CGM curves that you just showed there at the end, Chantal, mine look like that on many days, unfortunately, and that is still the struggle, even with the best technologies that we have today.
Can I come back to you, Kyle? I mean, I hear a lot of roller coaster, high, low. Was it always like that, Kyle? Did you have periods in your diabetes life, if I may call it that way, when it was different?
Yeah, and you may have seen me raising my glass of orange juice when Marjana was making her comment. I mean, just a very practical example of how I'm thinking about it, and it's there everywhere, and I need to be prepared. But to your point, Chantal, it was different at the beginning. It was different because I didn't need to. I feel like I just didn't need to get it as right as I need to get it today to have the same results. If I was looking at a curve like the ones you've just shown on the graph, they were just softer edges. The excursions weren't there. There was less, manipulation. It was less kind of modifications I was required to do throughout the day, and that actually makes a huge difference. As I'm sure others who've experienced this so-called honeymoon, it's exactly that. You don't realize it is because it's all so new, but it requires a lot less adjustments and thus a lot less excursions, particularly of a severe nature on either the low or high end. I just wasn't experiencing those in the first few years, and I remember it well enough. 24 years later, that difference, faded away, or that type of the way I was doing my therapy kind of faded and changed over the first year and a half.
Can I ask you, Kyle, how old were you then?
I was 16 years old.
16, so smack in your puberty?
Yeah, smack in my puberty, smack in my strive for independence with my parents. So there were definitely some exciting conversations in the household, but I was very well supported and well loved. So I'm fortunate for that. But even in those, in the best of circumstances, there were really tough days.
And this more easy life, how long did it last?
I think it was around a year and a half for me. It's, I don't have an exact number on that. And I feel like it was gradual. But I was someone who was particularly active with exercise. And so I would imagine, I wish I had the data, that I was producing some insulin back then, and my body was helping me in those first few years. And, in hindsight, I wish I could get that back. I really do.
So Marjana, do you remember when you were diagnosed, and did you also have what I see as a clinician, these first 1, 2, 3, 4 years sometimes are such an easy period. Did you also experience that?
I did, and similar to others that we've heard of, my diagnosis came in the form of a DKA episode. And my diagnosis took 2 years before we figured out. So even though I was diagnosed at the age of 10, I was symptomatic even back at the age of 8. And every time I'd go to the doctor, it was, oh, you have a bug or you have the flu. And unfortunately, it was just missed until, I was at the point where, walking into the emergency room, they could smell it on me. That's how high my blood sugar was at that point. And I had lost so much weight. I was probably 60 pounds as a 10-year-old child. And, it's a shocking way to have that diagnosis. And nobody in my family we didn't have a history of type 1. So nobody knew what to look out for, unfortunately, in my scenario. But as you said, Chantal, right after diagnosis, there was this period of time, I would say for about 6 to 8 months, that I actually wasn't taking any insulin. And, as others have sort of described it, sort of this honeymoon period, I think there's a little false sense of security there. You think, oh, I'm not really sick. And then when that ends, or when you start to have to sort of get back on insulin, and when I did, it was just basal insulin. I wasn't even taking any short-acting insulin for a good amount of time. And as others have said, I wasn't having those low blood sugars. I also wasn't having the highs either. So there was some sort of protection in there. And during that time, and as Kyle said, you know, even if I couldn't get off insulin, if I could get to a point where my, you know, my insulin and how I take it and what's happening is more predictable and that those curves are softer, that's really meaningful. I think that would be really meaningful to a lot of parents and to a lot of people with type 1. And, you know, we actually did a patient preference study just on this very topic to look at those levels of hypoglycemia, Chantal, that you just talked about that are not quote unquote severe, right? The less than 70 and less than 54, and looking at hyperglycemic events above 180, above 150. We included some changes in A1C and other measures, and predominantly the adults with type 1 and the caregivers of children with type 1 told us in that survey that their preferences were for managing the hyperglycemic events and the hypoglycemic events. And these did not include the severe ones. So I would tell you, even if I don't technically require assistance, I would consider an event where I'm not waking up to an alarm severe. Because if there wasn't somebody else there to help me, you know, that's problematic. So even though I may have sort of not lost consciousness, you know, less than 54, and even at less than 70, I have to do something, right? All of us with type 1, so as these alarms start to go off and they start to tell you, and, you know, a lot of people don't have continuous glucose monitors, right? We have to think about, what do I have to adjust, or what do I have to do now in order to avoid?
So Melissa, you see around you all these different stages. You have your child who has type 1 for a couple of months now, and then you have a child with longer, and then your husband with long-standing type 1. Do you see the burden being different? Is your child with only a few months diabetes, does he have or she have an easier job than your other child?
Actually, I think Connor, my newly diagnosed, is actually having a harder time than the other two. You know, my husband was 26 and living on his own, so he was able to make that adjustment for himself. My daughter was 3 years old, and at 3 years old, I kind of manage everything, right? And mom coming to every ballet practice and every play date is not embarrassing or even questioned. But when we're starting to talk about a 12-year-old, you don't want your mom hanging around all the time because she's worried about you having a low blood sugar. And also Connor has, you know, ADHD, and the way I am learning the relationship between his attention and his blood sugar. And when his blood sugar hits about 250, he's no longer able to really, the anxiety goes up and he's not really able to focus on school at all. And so waiting for that blood sugar to come down so he can have meaningful conversations with his teachers and classmates, that's been really challenging for him. And also he will remember not having type 1, where my daughter will never. This is kind of her reality always. So it's been a little bit more challenging for him. He also kind of knew for 3 years that he was going to get type 1 diabetes, and there's a certain kind of impact that weight has, always kind of waiting for that shoe to drop.
So he was really reflecting on that already as a child, what will happen to me?
Oh, definitely. Definitely.
And we discussed before, Melissa, you said even postponing a little bit would have been meaningful for me.
Actually, most definitely. You know, that frontal lobe isn't fully formed in a 12-year-old boy. So the longer that we
Is it ever?
So the longer we can wait, you know, Connor started on an insulin pump in February. We've already had to replace it once because the screen was cracked. Just this morning, I was down here working and I could hear him telling my husband, like, I don't know what happened, but the tube came out of his pump, right? Like, not sure what happened. So, I mean, he's just a typical 12-year-old boy that's really kind of had this extra weight put on him.
Yeah. So pushing it forward just a little bit?
Just a little bit, yeah. You know, 6 months, a year, even 3 months would be a blessing to a lot of families.
Kyle, you have a little baby now. How does your type 1 diabetes affect your life with your child?
It's been It's been an interesting year for me. I'm a new dad. My son Aaron is 15 months old, and I feel like in the last year, and even leading up to it, I kind of went back to diabetes basics in a way of just reminding me, I guess, how serious it can be, how quickly everything from driving a car to, just picking up and holding my little boy, who's just this little human being. It's completely dependent on me. What if, and of course, that's where my mind goes because of my experience with hypoglycemia in particular. I was hypoglycemic, unaware for a number of years, and only found that out, at the physician's office. And those kinds of things, I think, really hit home a lot stronger when it's family and when it's a baby. So it's been a time of recollection and remembering, how serious this thing called diabetes.
But I hear for you clearly, Kyle, hypoglycemia is very much at the forefront. And also your remark about the engineer not being able to predict what is ongoing, the variability. So I wasn't too far off there.
No, absolutely not. Yeah. And I mean, it's on the hypoglycemic side, when I wore a CGM device blind, and that's how they discovered I was hypoglycemically unaware, because I then went in and they downloaded it, and over the course of, I think it was a 10-day or something like that, I was in the hypo range something like 15-20% of the time. And during this period, my job was actually requiring a lot of driving. I was covering sales area of half the state of California, and I was driving every day. So just I had made a promise to my mom that before I took the wheel, I would check my blood sugar, and most of the time I did that. But it's again, it's just one of those kind of stock reminders of what if, and it's really frightening.
Marjana, you talk to many people. Can I ask you your message to clinicians, your message to researchers, your message to regulators? Where should this go? What is clinically meaningful to you?
So I think what you're hearing from many of us, and I agree with you, Chantal, the gold standard would be insulin independence, not being on insulin, not being on the thing that causes all of this trouble, if you will, right? All of the hypoglycemic events and hyperglycemic events. But until we get to that point, and we understand that will take some time, but if there are things that can protect us from those hypoglycemic events, and even the excursions on the other thing, for many of us, I think that's clinically meaningful. It affects how we feel, it affects how we function, and in many cases, it affects our ability to survive too. So I would say that, modifying this disease process, having interventions that alter the course of the disease, that get at the underlying effect of how type 1 diabetes comes about, is going to be essential and is such an important piece to eventually getting to that point, Chantal, for all of us, that cure, right? And even if we can buy ourselves some time, as Melissa said, I have 2 children as well. I worry about, what is in store for them. And I would like them to have options that would lead to better outcomes, even if it means not insulin independence right now, but this is the pathway. This is how we get to those cures, is that we have to address the underlying effect. And if in the meantime, if that's just leading to better outcomes in those short-term complications, as many of us are saying, that's important, I think, to many of us with type 1 and to many families who are caring for their loved ones, which, this is not easy, even with the improvements in technology and the improvement in insulin. Things are still very challenging, and many of us are not meeting those requirements or those recommendations to avoid those long-term complications.
Thank you, Marjana. Kyle, your final comments.
Well, just that resonates so strongly with me, and I mentioned it once before already. I'm an engineer by training. I've worked on medical devices for a big part of my life, and we have phenomenal technology. We've made incredible progress, and it helps. It helps a lot. But as we've heard from my fellow panelists, it's far from perfect. The status quo of living with diabetes is failing people living with diabetes. And I hate to say that as someone who's working on this progress, but we need to do better. And I think it's too easy to look at it as a formula. We can solve this thing without having a real understanding of what people are living day to day. And so I hope from my comments today, I've shared a little bit how intense that load is, that burden, how it impacts every aspect of my life, my family, my 15-year-old boy, and how I care for him. Have all been reminders of, how serious this can be.
Melissa, you have the final word.
I think I would echo everything that our other panelists have just said. I think I mentioned before we got started that our house kind of runs on insulin, right? And diabetes is always that running thread that goes through everything. We never get a break from it, but diabetes comes with us on vacation, goes with us to Disney World. It's not something that we can kind of put on a shelf and come back to later. And just not to go a day or two without thinking about it would be a blessing for us, because just the amount of energy it takes from our lives is great.
And so I will conclude from our panel that I heard very clearly that you all said 100 years of insulin is enough. We shouldn't have another anniversary. It's done. We need to do a better job at finding ways to stop this disease, to stop the progression. But I also heard that there are clinically meaningful endpoints where you would already be happy. If we could only give some relief for a couple of days, a couple of months, a couple of years, you would say, do it. Thank you all.